Mr. Chairman, ladies and gentlemen, first I want to thank Professor Marcelin that he invited me again for giving a presentation on cholestatic liver diseases and cholangiocarcinoma. These are my disclosures. I thought, how should I start the talk? And I decided for choosing again a case report and to introduce you into the subject. This is an elderly lady whom I met about 3 months ago on my outpatient clinic. She had developed in the summer of last year acute jaundice, severe itch, up to 9 of 10, gray feces, dark urine. She was very fatigued. She couldn't eat anymore, and she had a weight loss of 19% of her body weight. So this was really a severely ill patient. She had always been healthy. She didn't use medications, and she was proud of that. And the only thing what the doctors could find was a fall from the bicycle 1 month before. And as you know, in the Netherlands, everybody is using the bicycle, so this is nothing very special, falling from the bicycle. She had a nose fracture, no surgery, no real injury, and she was sent to the emergency ward of a peripheral hospital and was released, no treatment, no further treatment. The history of this patient, no relevant diseases in the past, in the family, 2 brothers with jaundice in the past, but she speculated that it was alcohol. She had been busy in funerals, in gastronomy, and also worked on a chicken farm. No traveling, toxins, no alcohol, drugs, or smoking, medication, 2 times tetanus vaccination after the fall from the bike. She gave me this photo for teaching purposes. And you see that she's carried by her daughter on the back of her daughter because she was so weak that she even couldn't walk around anymore. When I saw her, this was 3 months later, she was very exhausted, icteric, and she had scratch lesions on arms and legs. Otherwise, no relevant diagnostic findings. This is a lab, and everybody here knows this kind of pattern. High bilirubin. This is about 15 milligram per deciliter of bilirubin when you use milligram per deciliter. The ALT and the AST slightly elevated, and it's a cholestatic pattern. Ferritin slightly enhanced, but the transferrin situation normal. In the other hospital, many studies had been done to find a diagnosis, but all was negative, as summarized down there. And this is, again, the diagnostic approach which we use and which we recommend in the EASL guidelines for PBC and for cholestatic liver diseases in general. When you have cholestasis, after detailed histophysical examination, serum liver test, you do the ultrasound. And this was the ultrasound, normal aspect of the liver, no focal lesions, no stones in the gallbladder, no bile duct obstruction by stones or mass. So no diagnosis. We have done later the fibroscan, which was 7.1. So this was not a long-going story in this patient, more an acute event. And she also had no fatty liver, the CAP value was normal. When you do that, we recommend always using, particularly for female patients, elderly or middle-aged female patients, AMA, anti-mitochondrial antibodies, and the PBC-specific nuclear antibodies, SP100 and GP210 for PBC. And let me just start with the PBC, give a short update on PBC. We make the diagnosis of PBC with cholestatic markers, alkaline phosphatase, gamma GT elevation, plus anti-mitochondrial antibodies. And the most specific is the PDC-E2 antibody. It's directed against the pyruvate dehydrogenase complex, which turns pyruvate into acetyl coenzyme A. These patients, particularly in later stages, many of them suffer from fatigue and pruritus, the majority, and the majority also has symptoms of Zika syndrome, dry eye, dry mouth. The pathogenesis, 20 years ago, we speculated, or this was the general view on the pathogenesis in PBC. There is an immune-mediated bile duct injury, which we did not understand. A lot of studies have been done on genetic predisposition, environmental factors still are done, particularly in Newcastle, cellular and humoral immune response, and a lot of data have been collected. But a real explanation for PBC has not yet been found. And we thought then that the damage can be aggravated by hydrophobic bile acids in bile, and that then cholestasis will lead to fibrosis, cirrhosis, and liver failure. But already in the 1990s, the Spanish group from Pamplona, and you just had a talk from Pamplona, and now also from San Sebastián, proposed or investigated the possible role of bicarbonate. And they had found, Dr. Prieto had published that PBC patients have less bicarbonate secretion into bile than the healthy persons. Interestingly, ursodeoxycholic acid improved bicarbonate secretion in PBC patients, as shown by Dr. Prieto at that time. I have been long thinking about what could this bicarbonate mean. Human beings produce much more bicarbonate than mice or rats. And one of the differences is we have different bile acids. Man has different bile acids from rat and mice. And one of the key differences is the conjugation. We have glycine conjugates, the majority, and animals have taurine conjugates. And the difference in these species is the pKa, and you may remember from your chemistry that the protonation of molecules depends on the pKa. So the hypothesis we generated was cholangiocytes, which secrete a lot of bicarbonate, may protect themselves by keeping the bile salts as bile salts negatively loaded and not allowing bile acid formation, because this is an apolar molecule which can invade cells without transporters, and then the cells are damaged. In PBC, meanwhile, and I don't have the time to go into detail, we know that several aspects of several components of the biliary bicarbonate umbrella machinery are defect. And interestingly also, not only the AT2 is downregulated in the microRNA 506, which regulates that, is upregulated, but also there is a secondary aberrant expression of the PDCE2, the antigen which is detected by the antimitochondrial antibodies in PBC. So the immunological response could be secondary. This is our view today about the pathogenesis of PBC, a defect possibly of the biliary bicarbonate umbrella, and as a secondary phenomenon, immunological effects. This also explains why ursodeoxycholic acid is today the standard therapy, and this is our view since a couple of years, and there we have Dr. Poupon, Dr. Janssen, Dr. Trauner, myself. We share this view that stimulation of hepatocellular secretion and stimulation of cholangiocellular secretion are key mechanisms for the beneficial effect of urso in cholestatic diseases. And this is also valid for bicarbonate secretion, because ursodeoxycholic acid, also on the cellular level, is stimulating secretion of bicarbonate. How is it doing it? This is a summary of 15 years about it's apparently a post-transcriptional stimulus of secretion by inserting key transporters in the apical membrane of the hepatocyte and also the cholangiocyte. These are chloride channels in the A2, anion exchanger 2, which exchanges chloride versus bicarbonate. For treatment urso, we know today urso helps 2 of 3 patients and they have a normal life expectancy, but there is 1/3 of the patients who are incomplete, we call it in 2020, incomplete responders, because from this study from the global PBC group, we know that even the incomplete responders who do not have adequate response to 1 year of ursodeoxycholic acid treatment, here validated by evaluated by the GLOBE score, which is the most sensitive in predicting prognosis, have a benefit versus non-treated patients. So today we should treat every single patient with PBC with ursodeoxycholic acid. And you see the difference between incomplete responders and untreated patients. In my view, a very interesting paper. What other options do we have at this moment for PBC? Obeticholic acid is already mentioned several times, the FXR agonist, and it has been shown, as published in the New England by Nevens and colleagues from many different centers and countries, that it significantly improved alkaline phosphatase and patients in a significant amount in comparison to patients treated with urso alone, all incomplete responders, reached the so-called POISE criteria, alkaline phosphatase below 1.667 times normal with a better prognosis. These are the former Toronto criteria. What does an FXR agonist? An FXR agonist protects against toxic effects of hydrophobic bile acids. And bile acids are usually the ligands of the farnesoid X receptor, and here you see obeticholic acid, which is 100 times more potent than chenodeoxycholic acid, one of our hydrophobic bile acids. And it suppresses expression of uptake transporters, and it stimulates expression of export pumps to keep the cell free of as good as free of toxic bile acids. And also metabolism, biotransformation, phase 1 and 2 enzymes are upregulated. And escape valves like the Ost-alpha beta back to blood are upregulated. So the cell interior should be free of bile acids. The other one is the PPAR agonist bezafibrate, and there was a very nice paper of Corpechot and colleagues here from Paris, from Saint-Antoine, who clearly showed, with the whole French group, who clearly showed that bezafibrate is superior together with urso, is superior to urso alone in incomplete responders. And more than about a third of the patients completely normalized their serum liver tests under the combination of urso and bezafibrate. So this will, it's not yet FDA and EMA approved, but this will be a second-line therapy in the future, and it's a cheap therapy. The bezafibrate has a different mechanism of action, and this is for PPAR alpha, but bezafibrate is a broad PPAR agonist, also delta, also gamma, and it inhibits NF-kappa B dependent inflammatory processes, which is of interest. And it also decreases bile acid synthesis. This is the key enzyme CYP7A1 for bile acid synthesis. And in addition, it apparently, at least in models, increases phospholipid secretion, which again co-stabilizes the biliary bicarbonate umbrella because there are less free hydrophobic bile acids in the lumen of the bile. And there are usually high millimolar concentrations of bile acids in bile, and the free monomers are still in millimolar concentrations above the membrane. So this makes a lot of sense for the concept of the impaired defense by impaired bicarbonate secretion. We are waiting for results of budesonide, which will come out later, maybe this year, to then also have an EASL recommendation for second-line treatment, bezafibrate, maybe also budesonide, but this may be 2-week data. Just one. This is a complex slide, and I don't want to lose too much time. Itch this patient was very strongly itching. We have a concept how itch may work, and cholestyramine, rifampicin, naltrexone, sertraline are our basic medications. ASBT inhibitors, this is the uptake transporter for the bile acids in the ileum, may play a role, and we did the FITCH trial and just showed the data in Boston, where we could show for PBC and for PSC significant improvement in itch, which these results, I have to say, made me very happy without major side effects. In our patient, the AMA and ANA were negative, and the next step would then be the MRCP. But our colleagues from the other hospital already had provided a CT of the abdomen because they had considered cholangiocellular carcinoma as a possible cause of her jaundice. And the CT showed normal aspect of the pancreas, normal aspect of the liver, but perihilar bile ducts appeared to be slightly thickened, otherwise no abnormalities. Then you think of in the direction of sclerosing cholangitis, and PHC is the best characterized sclerosing cholangitis. I also don't have the time to go in detail to this. In the Netherlands, we have a 21-year transplantation-free survival. This is, at this moment, the best reported. We treat our patients with ursodeoxycholic acid, and I'm a strong defender of that. France has the second best results with 16 or 17 years transplant-free survival. The therapy at this moment, we still don't understand the pathophysiology. The therapy at this moment, liver transplantation is the only proven beneficial treatment, and ursodeoxycholic acid. And when you have dominant strictures, endoscopic balloon dilatation, less side effects than stent placement for treatment of the stenosis. There's a lot going on this field. But not yet. We do not yet know where the way will go. Like the Paris group, I favor the PPAR agonists as a possible future treatment option, but we have to wait for data. We don't have enough data at this moment. Then when you see sclerosing cholangitis or aspects of sclerosing cholangitis, you always have to exclude the secondary sclerosing cholangitis. And cholangiocarcinoma and IgG4-related cholangitis belong to this. Cholangiocarcinoma, as you may know, the majority is the perihilar cholangiocarcinoma, the Klatskin tumor, where also our patient had slight abnormalities. The intrahepatic cholangiocarcinoma is increasing in prevalence, but it's still in this statistics 8%. And then there is the distal cholangiocarcinoma. This is a very large study 10 years ago, but from Tanja Wetzel, who showed risk factors, associations of medical conditions with cholangiocarcinoma, like choledochosis, cholangitis, biliary cirrhosis, cholelithiasis, and cholecystitis, but our patients had none of those. There is a lot going on now, but 10 years behind of hepatocellular carcinoma, on possible treatment options for the future, and we just heard on immune therapies. But what we already did was learning how the activated cholangiocyte functions, and it has an intense interaction with the immune system, both the cellular system and the humoral system, and also for proliferation of cholangiocytes. We have to understand the exact mechanisms to interrupt these pathways in order to develop effective medical treatment. At this moment, we are behind. IgG4-related disease mimics primary sclerosing cholangitis and cholangiocellular carcinoma. And when you see these cholangiograms, for the second one, for example, you think this is a cholangiocarcinoma, but it was also an IgG4-related disease, and this stenosis completely disappeared after treatment with prednisolone. And the misdiagnosis, therefore, is common. Our patient had normal IgG4 in serum, but only 70 to 75% of IgG4 patients have elevated serum IgG4. So the sensitivity is not very high. And this is typically a disease of the elderly male. The age was correct, but elderly male. Jaundice, weight loss, also our patient had that, but no elevated serum IgG4. And here you see also the autoimmune pancreatitis in this case from my outpatient clinic. The diagnosis is made by the high-sort criteria, including the histology, and it's difficult to make. We found a couple of years ago that this is a clonal disease. B-cell clones are prominent in blood of these patients, and you can make a difference between IgG4-related cholangitis when you screen for B-cell clones in comparison to healthy controls. The first IgG4 clone only appears at number 100 of all IgG clones, and in disease controls, including PHC and cholangiocarcinoma. And these clones completely disappear under prednisolone treatment, which is the treatment of choice for the first months. We also saw that blue-collar work is probably a risk factor, long-term blue-collar work, which includes all professions with oil or with diesel or with products, exposure with these products. In our first series, 88%. Now it's about 75% of all patients. We oversee about 100. I go over this. And when you still don't have the diagnosis, you make a liver biopsy. With this 80-year-old female patient, I was doubting that I should do a liver biopsy at this moment. And when you, in the liver biopsy, don't find the answer, you can consider genetic analysis in specific patients when you have suspicion of ABCB4 deficiency or other defects. For the website, I added all the defects we know, the rare diseases which are caused by genetic transporter defects, but I will keep it here with just showing what we already found. We have, meanwhile, not only PFIC, progressive familial intrahepatic cholestasis type 1 to 3, but also 4, 5, 6, and this will continue in the future. Persistent hepatocellular secretory failure, this was one idea, what the patient could have, an increase in bilirubin due to an agent, like toxins or antibiotics, but also due to choledocholithiasis short-term, that the patient does not recover. And this case series we published a couple of years ago. When you use rifampicin, it goes away within 2 weeks. And it was, I treated almost all these patients. And very impressive by activating PXR, the pregnane X receptor, in order to get better secretion of the hepatocyte. The diagnosis, last slide. Do you have the diagnosis? Yeah, I called during that hour with this patient, her sister, her daughter, and asked whether she had any information about the hospital stay in the emergency ward when she fell from the bicycle. And here you see, this is what they wrote up: Augmentin 3 times per day, 1 tablet, and 5 weeks, 6 weeks later, she got jaundiced and with heavy pruritus and so forth. So the diagnosis in this patient is clavulanic acid-induced liver injury. And beside the steps which we do, diagnostic steps, I recommend to you, take history again and again and again. Thank you very much.